It's my pleasure to introduce our conference opening speaker, Dr. Lorelei Lingard. Lorelei is a leading researcher in medical education and in healthcare, and we're proud to have her as a Canadian. Her special focus is teams, healthcare teams, communication, collaboration, and she brings a special lens to that you're about to witness. She's truly one of medical education's world gurus, and we're really happy to have her here. We tried to get her a couple of years ago, and this is the day we could get Lorelei Lingard to be a part of it, and we feel so lucky that she's presenting today. She's professor in the Department of Medicine at Western University and is the inaugural director of the center there, the Center for Educational Research and Innovation at the Schulich School of Medicine and Dentistry. As I said, she's a world guru in communication and collaboration. So without further ado, will you please welcome Dr. Lorelei Lingard. Welcome down.
Thank you. Good afternoon, everyone. I don't think I need that, but thank you very much for the invitation. I'm glad I was able to come this year. I was to come in the past and couldn't make it, so this is really a special treat for me to spend this afternoon with you talking about collective competence and the question of adapting our concept of competence to healthcare teams. And really, the underpinning question is, are we there yet? Are we ready to do this? Many of you will know that I've spent my career studying healthcare teams. I'm maybe best known for the work that I did with operating room teams. I spent over a decade hanging around in operating rooms, listening to people talk, watching how their talk influenced their ability to practice collaboratively, and watching how trainees learned to talk that talk and what it meant to do so. I've always been interested in language. I'm trained as a rhetorician. And what that means is the study of the social uses of language. I'm interested in what language does in healthcare and what it does on teams and what it does in training. Increasingly, I've become interested in this word, the word competence. Why? Competence, I would argue, has become one of our predominant ways of seeing. The 20th century rhetorician Kenneth Burke said that every way of seeing is a way of not seeing. So how we see competence shapes our attitudes towards what we're teaching and assessing, what it is we're creating in a health professional, and it influences what we end up doing, the actions we take as a consequence of those attitudes. Competence selects some things for our attention, and it deflects our attention from other things. And that's what a way of seeing does. It focuses you in one place, but presents a blind spot in other places. You can't ever see everything. Competence is also a God term. This is another great word from Kenneth Burke. He's almost impenetrable to read, but he has some really great take-home ideas. God term is one of them. What he means by God term is an expression to which all other expressions are ranked as subordinate. Competence isn't the only God term that we throw around. Patient safety is one. Objective evaluation is another. Patient-centeredness. These are all God terms. And my way of thinking about them as rhetorical trump cards. If you're sitting around any educational committee meeting and somebody plays the trump card of competence, it's very hard to come back from that. It's very hard to argue against it. If you're in a clinical meeting in a hospital and someone plays the trump card of patient safety or quality of care or patient-centeredness, it's a God term. It's very hard to argue against that. So for me as a rhetorician, any piece of language with that kind of power requires intense scrutiny. I want to know, what do we exactly mean by that word? What is it doing for us? What are we doing with it? And what are we not doing with it? So my objectives this afternoon are fourfold. I want to talk about our conventional way of seeing competence as a prelude to introducing a different or emergent way of seeing competence. The third part of the talk, I'm going to ask the question, are we there yet? And I'm going to present to you my analysis of the CanMEDS 2015 document, which went online in September of this year. And in the fourth and final part of the talk, I'm going to talk about the power of metaphor and what it would mean to move forward productively. But first, I'm going to admit that I've been talking about collective competence since 2008. 2008 was the first time at the Ottawa meeting in Melbourne, Australia, when I got up and gave a keynote about collective competence. And then the next year I presented an editorial, and a few years later I presented a book chapter, and I've been giving this sort of keynote revised, and I wonder a little bit if I sound like the person Calvin's talking about. I'm up on my soapbox and I'm beating everyone over the head with the idea of collective competence. But in fact, the reason I'm still talking about it is A, it's such a thorny issue, and B, every time I present it, I get very provocative, challenging questions. So in 2008, basically my message was, isn't it interesting that when we talk about competence, we mean this and not that? And I got a series of provocative questions. And each time, the last couple of years when I've talked about this, the provocative questions are really about, is this really possible? Can we really talk about collective competence in medical education? So this iteration of the keynote, it's about half brand new stuff. And it's really me trying to grapple with the, really, could we really do collective competence in training and assessment? So part one, our conventional way of seeing. We have a pretty tried and true recipe for making physicians. And when I study healthcare teams, one of the things I learn over and over again is that healthcare is full of highly competent physicians, because we're pretty good at making them, actually. How do you do that? Well, we spend a lot of time thinking about how we make sure we get the right people to start with, selection and admissions. But once we have them, in essence, it's pretty straightforward. We fill them up with knowledge and skills and attitudes. We get them to perform the stuff we've filled them up with so that we can assess and document and credential their competence. And if some of their competence leaks out, we refill. We've been concerned about maintenance of competence in the last decade or so. There are some basic premises that underpin this approach to competence, a very individualist approach to competence. And these are the three main ones. The first is that competence is a quality that individuals acquire and possess. They come in without much of it, we fill them up, it's in them, we see that it's in them, we rubber stamp them. The second related premise is that competence seen this way is a state to be achieved. You can get it, you can get there. And related to that is the premise that, therefore, competence is context-free. It's relatively untied to time and space. You filled me up with it, I achieved the state, and it's largely context-free. This individualist notion or way of seeing competence influences everything we do in medical education. Who we select, how we teach them. Even when we're teaching them in group-based settings like PBL, we're really interested in what the individual is learning, and that's what we're assessing for. How we license, how we credential, how we monitor. And when we smell a problem somewhere in the care process, notwithstanding a decade and a half of safety science literature, we tend to look for the most responsible individual practices or people, pull them out, remediate them, put them back in, and hope for the best. Individual competence everywhere, threaded all throughout our educational practices. It has very strong theoretical roots in our domain. The dominant learning theories in medical education are adult learning, reflective learning, and experiential learning. And each of these is highly individualist. It takes the learner as the active agent at the center of the activity of learning. And this individualist way of seeing competence reflects a particular historical and professional context, the one which produced it 100 or so years ago. And that is the context of the patient being cared for by their individual physician. And in the era which produced it, this way of seeing competence was likely sufficient. But the times have changed. This is a CIHI report from 2011, which describes just exactly how they've changed. About a quarter of all Canadian seniors report having 3 or more chronic conditions. And those seniors report over 13 million healthcare visits per year. We're no longer in the situation where the individual physician is caring for their patient. These are patients who are having to see multiple care providers, medical and other health professional, and no individual physician or health professional can competently provide their care. The times have changed. We have taken to saying, therefore, that healthcare is a team sport. This is a happy metaphor, and the less happy metaphor is that healthcare is a maze of disconnected care episodes. There's a great debate about whether team is the right word to use at all, and it's a very worthwhile debate to have. To give some texture to this, I want to share with you a story. This is Joe. Joe's an 80-year-old man who lives at home alone since his wife died a year ago. He had his first heart attack at 55. He's had 3 more since. He's been a diabetic for 25 years, and as a consequence, he has some mild kidney troubles. About a month ago, Joe was admitted to hospital with a pneumonia. And while he was in hospital, his kidney troubles worsened due to a drug side effect. So the hospital doctors stopped that drug. Joe improved. He was discharged home. About a week after his discharge home, Joe has a follow-up appointment with his family doctor. His discharge summary hasn't yet reached the family doctor's office. Joe arrives with his pill bottles, including the bottle for the pill that was stopped in hospital, because Joe started taking it again. He didn't realize that he shouldn't. Now, the family doctor has some concern about the blood sugar results from a test before Joe's hospitalization. And she's concerned that his blood sugar medication is not controlling his sugars properly. So she tells him he should see his diabetes specialist, and she refers him. A couple weeks later, Joe visits that diabetes specialist, who shares the family doctor's concern about the sugar control. The specialist is worried that his current medications aren't working well enough, so he prescribes a new medication. And Joe fills that prescription at a different pharmacy than the one he usually goes to because he's coming home from another city. Now, if the diabetes specialist had realized that Joe was having kidney troubles in hospital, he wouldn't have prescribed this medication because it's not to be used in the context of kidney failure. But the discharge summary wasn't sent to the diabetes specialist office. Joe also has daily home care. And in the past few days, since he started his new medication, the home care nurses have noticed that he's having shaking and sweating episodes. And they wonder if this is due to a low sugar reaction. But Joe doesn't reliably check his sugars, so there's no way to be sure. They recommend that he go back and see his family physician, and they note their concern in the home care binder. About a week following the start of his new drug, Joe's daughter arrives at his apartment to pick him up for church. When he doesn't answer the door, she goes in and finds him in bed having a seizure. She calls the paramedics, who correctly diagnose him as having profoundly low sugar reaction, and they initiate treatment and take him to the emergency department. Does this sound familiar to anyone? What's going on here? One could argue that in each of these care episodes, Joe interacted with an individually competent care provider. He recovered from his pneumonia in hospital and went home. His family doctor, based on the information available to them, was concerned about the sugars and sent him to the specialist, and so on and so on. Each of these individuals, within their scope of practice and acting on the most current information available to them at the time, provided competent care for Joe. But the sum total of those care episodes is not competent care. Why not? Because Joe is the iconic patient described in the CIHI report. He sees many providers, he has multiple things going on. The lesson here, and we all know it, but it's worth putting on a slide, is that individual competence does not equal good health care. So So the second part of my talk is to describe for you an emergent or different way of seeing competence. Not to say we shouldn't see individual competence, but to say, what else is there to see in a situation like this? I want to frame this, though, with a few truths from the study of teams. I've studied operating room teams and primary care teams and adult rehabilitation teams and internal medicine ward teams and pediatric medicine teams and transplant teams and most recently heart failure and palliative care teams. And I can tell you that there are a few things that always hold true. The first is that competent individuals can form an incompetent team. The second, and this is very intriguing to me, is that a team can be competent even when one member is incompetent. If this weren't true, nobody would survive a July admission to hospital, would they? The third truth is that an incompetent individual can paralyze one team, but the same individual in another team doesn't paralyze the team's work. They carry on, they neutralize or reorganize. And I've had many opportunities to see this because people travel through different teams. So if you're observing in any clinical setting, you get to see this individual who's a thorn in the side of this team and derails it does not have the same effect in another team. And finally, a team can be competent one day or in one set of circumstances, and the same team be incompetent in the next set of circumstances. Now, how can all of these things be true? Well, they can be true because individual competence doesn't equal collective competence. I introduced in this book that Brian Hodges and I co-edited in 2012 the phrase collective competence to our domain. It had been used before in the education literature, and I introduced it as a way to see aspects of competence that aren't reducible to the individual, but emerge instead from social, organizational, relational systems or aspects of practice. If I had to boil down the key premises of collective competence, they are these: that competence is a constantly evolving set of multiple interconnected behaviors, and that it's achieved through participation, and it's enacted in time and space. It too has theoretical roots. I didn't make this up. It actually, you can trace it back through various theories, including Hutchins' theory of distributed cognition, where he argues that collaborative work is a joint cognitive accomplishment that's not attributable to any single individual. Now, consider your work in any clinical setting, and you will see that this is true. The product of clinical work on an internal medicine ward or in the emergency department is not attributable to a single individual, which is why it's so very difficult when something goes wrong to trace back the cause to a single action by a single person. It also has theoretical roots in learning theory, particularly situated learning theory, which argues that competence emerges through social interaction, through shared experience, development of tacit strategies and knowledge, and through innovation, largely in response to implicit situated needs. And finally, one of the richest theoretical sources for the idea of collective competence is sociomaterial and systems theory. Theory like activity theory, actor network theory, complexity theory. Just a few points from this that I want to drive home. The first is Angstrom's point that individuals are shaped profoundly by the social, technological, and physical structures of their work. It's impossible to think of competence without thinking of those other structures, as far as Angstrom would be concerned. And finally, complexity theory argues that complex systems are inherently unstable. A change anywhere creates a ripple effect, which is largely nonlinear, which means that competence, far from being stable or context-free, is highly context-dependent. So to summarize, what I've laid out here are two ways of seeing competence. An individualist way, which sees competence as an individual possession, a stable state that can be achieved that's largely context-free, and a collective way of seeing, which sees competence as a distributed capacity of a system that's evolving and very firmly based in situation. What's really important for me to make explicit at this point in the talk that I'm not presenting a simple binary opposition. I'm not saying one is good and one is bad, nor am I saying that one is the solution to the other. What I'm saying is that each of these ways of seeing competence selects some things for attention and deflects our attention from other things. Each has its emphases and its blind spots. In order to give some texture to that, I want to share an example from observational field notes on an operating room team, and then think about what would we notice if we looked at it from these two ways of seeing. So during a liver resection, the surgeon requests more sponges due to heavy bleeding. She asks the anesthetist what the central venous pressure is, to which the anesthetist responds, 15. The surgeon raises her head. What? 15? No wonder we've got all this bleeding. Shakes her head and says to the resident, it should be kept less than 5 when we're transecting the liver. We're going to have to try and hurry this up. The surgeon then asks the anesthetist, can you lower the CVP? To which the anesthetist responds, yes, but he won't tolerate a CVP less than 5. He needs a high preload to maintain output. To which the surgeon responds, if you don't lower it, he's going to lose a lot of blood, and that won't be pretty either. So if we were to look at this from an individualist competence way of seeing, we would ask particular kinds of questions. Top among them being, what do the individuals in the situation know? For instance, does the anesthetist usually do liver resections? Does the surgeon understand the timing associated with lowering the CVP? Does the surgeon remember about the heart condition that the patient has, etc.? We would also ask about individual skills. What are their communication skills? How effective are they at negotiating conflict? And asking these kinds of questions can be very useful, can reveal areas of individual weakness that could use remediation and improvement. But they're not the only questions we could ask. If we took a more collectivist approach to this, we would ask questions like, what is the access to information across the group? For instance, are team members aware of what others know and what they don't know? We would ask, what are the similarities and differences in their perceptions of some key things? In this case, what are their similarities and differences in their perceptions of the patient's status? In their perceptions about the advantage or disadvantage of a lowered CVP, their perception of how problematic this much bleeding is, their perception of whether we're in an emergency or not. These shared or unshared perceptions are part of what would produce collective competence or not. And these are the kinds of questions we would ask if we took this way of seeing. So I've laid out for you two ways of seeing competence, an individualist way, a collective way. I'm not arguing that one is good and one is bad, but that they attune us to different things and they deflect our attention from different things. So in this chapter of the talk, I want to address the issue, are we there yet? Can we actually see both ways in training and assessment in our current competency-based medical education framework? So I went online and I did an analysis, not a deep linguistic analysis, but an analysis of the CAMMEDS 2015 draft that's available for public feedback. And I'm asking the question, what's in here for us to actually start seeing competence both ways? I'm not going to illustrate how the individualist way of seeing is in here, because that's the bedrock of the framework. It's all over the framework. What I went looking for is phrasing, language, considerations that would tune us towards the collective. Obviously, the first place I looked was the collaborator role. It's actually a common question or comment for me to get when I give the collective competence keynote for someone to come to the microphone and say, but we have this. It's the collaborator role. We do this already. So this is the first place I looked. Is the collaborator role the home of collective competence? Here's the summary of the role. As collaborators, physicians work effectively with other healthcare professionals to provide safe, high-quality, patient-centered care. Sounds good so far. And if I go through, you don't need to be able to read these, but this is me going through and circling in red all of the key concepts that are relevant to taking a collectivist way of seeing competence. So things like collaboration with community provider, handover, transitions of care, team dynamics, et cetera. There's a lot of stuff in the collaborator role that's talking about a collective understanding, a collective approach. In particular, the new handover competency. If you think about Joe's story, the handover competency is very relevant. Effectively and safely transfer care to another healthcare professional. So this is obviously relevant language for a collective way of seeing. You can find it in other parts of the framework too. In the medical expert, continuity of care, timely follow-up, working within the team. In the communicator, appropriate documentation, etc. In the leader, there's a lot of interesting concepts and enabling competencies around systems thinking and understanding how systems work. And in the health advocate, the idea of mustering resources as needed. There's language in the framework that positions us to think about collective competence. There's really good stuff in there for us to use. Now what? Well, what we tend to do is apply that language to individual trainees. We fill them up with these competencies, which are really nicely articulated, and we assess their individual performance. So take as an example Emma, who's an eMERGE resident. We have an ITER that we use to evaluate whether Emma has achieved certain competencies. And so, is this an equation or a formula for collective competence? If we can check that Emma has collaborator 1.1, 1.2, 1.3, et cetera, medical expert 1.3 and 1.4, communication, you get the point. Does that equal collective competence? No, because there are two ways of seeing competence. And the ITER is reflective of the first way. The ITER is based in the premise that competence is something Emma possesses, so I can fill out a form on Emma and see that she has this competence. What about the other way of seeing competence? What about the distributed capacity of competence in the setting in which Emma has to work? What about the evolution of that competence as that setting shifts and the setting is so fluid? eMERGE is a great example for this. And what about its situation-specific nature? Well, we have a strategy for this. And this is what I'm hearing in conversations when people think about, well, I think we can do this. We have the tools, we can do this. We evaluate Emma, and we evaluate Ravi, and we evaluate John, and we evaluate Scott. And if they all have all of these tick boxes multiplied by all team members, then do we have collective competence? I mean, it's a bit absurd, that's why you're laughing, but no, we don't. But this is the inclination. And the inclination is individualist. We're still working with individual pieces, even though we've got some really good language to help attune us to collective systems kind of competence. Why is that formula not the answer? Because we all know that competent individuals can form an incompetent team. So everybody having all of those check boxes does not guarantee collective competence. Which brings me to part 4 of the talk, the power of metaphors. Or, otherwise titled, Why We're Stuck. Because I think we're a bit stuck. I think one of the main reasons we're stuck is that this is our main metaphor for healthcare teamwork. That there's a bunch of parts, and if all the parts are working properly, then when we put the parts together, we'll have a smoothly functioning team. And over again in the study of teams, I've had people say to me, or I've observed people saying in their team setting, listen, if everyone in this room just knew what they were doing, this would all go smoothly. If we were just all here and we did our job, then there wouldn't be any problems because we'd be a team. Joe's story makes really clear the futility of that and the inappropriateness of the metaphor. Because although we could quibble about some of the details, I think it would be fair to say that Joe had a series of competent interactions with parts of a system, and it was in the cracks in between those episodes that things went wrong. I mean, there are a number of ways to summarize Joe's story. One of them is that he passes through the healthcare system more quickly than his updated information does. That is not a problem with the competence of any individual. It has to do with the glue, the informational glue that holds the system together. So my point here is that patients like Joe, patients like the quarter of Canadians represented in the CIHI report, will fall through the cracks between individually competent providers who all got check marks on all of those competencies. Why is this? This is because a healthcare team is a complicated system, is not a complicated system, it is a complex system. And the difference is quite important and quite straightforward, really. The main difference is that in a complicated system, the elements of the system and their connections are equally important. So, the gears and the connections between the gears are equally important in a complicated system. And there are simple algorithms that produce simple and predictable responses because of that equal importance. And responses are pretty fully determined. They're pretty linear and predictable in a complicated system. But in a complex system, the connections are actually more important than the individual parts. So the cracks in between cannot be outweighed by excellence in the individual episodes, is what a complex system theory would tell us. Simple rules produce a variety of adaptive responses because there's a latitude possible in responses because connections are important and connections are unpredictable. So if we take the healthcare team as a complex system, then a far better metaphor is something that is a complex system, not a machine. One example, it's actually quite a popular metaphor in studies of complexity and teamwork in other domains, is the metaphor of flocking or murmuration, where it's not about the individual bird, it's about the flock and how they read the 5 or 6 birds around them. One of these birds can fall out of the sky and the flock will continue on. And what influences the way the flock moves is not individual birds and their excellence. It's wind, it's geography, it's disturbances in either of those. So do you see how this metaphor takes us outside the individual and says the individuals are there and they're functioning, they're really important dimensions of them that we have to capture, but there's more going on. Now maybe it's because I have a PhD from a Department of English, but I think metaphors are enormously powerful, in part because they're usually hidden. We don't usually say explicitly, we use a machine metaphor to talk about teams, but if we listen to ourselves, we do. And they're that much more powerful because they're sort of invisible to us. So this I would propose, or something like this, is a better metaphor. Now, in this metaphor, does individual competence matter? Sure it does. But is collective competence a whole lot more difficult to teach and assess if we take this kind of metaphor rather than a machine metaphor? Absolutely, it's more difficult. Is this our problem? This is another recurrent comment I get when I talk about collective competence to medical education audiences. The comment that we're really in the business of producing competent physicians. And we have to license individuals, and medical legally, it's all centered on individuals. And Absolutely, I get that there's a whole structure and infrastructure that has made individual competence really, really salient for us. But it doesn't mean we can say it's not our problem. We're producing individuals to work in a system, and therefore I think the complexity of having to try and teach and assess through a collective competence lens as well as an individual competence lens, it is our problem. And it's our problem because, once again, the goal is not individual competence, the goal is good health care, and the two are not equated. Over and over again, we experience them as not equal. Now, don't get me wrong, I'm not saying this, not exactly. But I am saying that we need both ways of seeing, and that we need both ways of seeing in postgraduate training for physicians governed by the Royal College. How are we going to do that? This is an enormous challenge, and what I'm going to try and do now is really just make some suggestions to start a conversation about how we would do that. The first is, I think we need to be aware and wary of our metaphors, particularly the mechanistic metaphor. The second is, I think we need to evaluate in situ. We need to evaluate interactions. We need to consider interactions beyond the people, and we need to capture the cracks between care. Now, I'm going to deal with each of those four individually, very briefly. Evaluate in situ. We know we need to do this. We've been talking about trying to do this for a long time. And I actually think that the shift towards milestones in CanMeds 2015 is going to promote this. It's going to make it even more unavoidable. We need to observe and evaluate actual practices, because if we're looking at actual practices, it's very hard just to see Emma. It forces us to see Emma in context. And we need, I think, to broaden our focus beyond individual actions in context, which could still just produce another ITER, to interactions among elements of the context, individuals, for instance. The milestones document actually begins to include some really good language that tells us that being observant about interactions and being aware of and trying to anticipate what interactions might happen are important. So this language is already in there. We're poised to do this kind of work. This is not incongruous with what the 2015 draft is describing. I also think that there are some tools out there already that we can begin to look at for hints about how we would do this. I don't think there are any in medical education precisely, certainly not any that I know of, but there are some very long-standing tools for analyzing interactions in the patient-provider communication literature. Deborah Roeder's tool, for instance, very long-standing, valid tool. There's also some tools in the educational psychology and classroom assessment literature that my new colleague, Saad Shaheen, pointed out to me just this week. But that's not sufficient, because those are just dyads. And a collective isn't a bunch of dyads, it's more than that. So those tools might help us, they might be a starting point, but I think we need to move to evaluating interactions in the collective and not break that into a bunch of dyads. The scientists who've been working on teamwork and safety, particularly Eduardo Salas's group in Texas, they've done some really good research work developing tools to assess criteria, to assess teamwork, and some of their main criteria are things like adaptive behavior, shared mental models, situational assessment, and they've developed valid tools for this. The struggle that that discipline of science is now encountering, but it's our struggle too, so we can go through it with them, is moving that from a research application to a widespread practical application. This is a really interesting book published a few years ago that has a whole section on that struggle. The tools are developed, they work pretty well in research settings, but a sort of a widespread, the kind of thing we're talking about having to do, there are a lot of bugs that need to be worked out. But it's a start. I also think we need to attend to more than just the people. Right now, it's really amazing to me when I read the CanMeds 2015 document how focused we are on people. Now you're going to say, well, isn't that a good thing? We're a people-centered profession. Well, it is a good thing, except it's creating a blind spot, and I'm not sure we're aware of it. It's deflecting our attention from all the other elements in the system that the people need to do their work together. Just a quick peek at the collaborator role. What I've circled here is some of the references to providers, professionals, colleagues, individuals, all the references to people. They're all over the document. We need more attention to all the other, what socio-material theorists would call socio-material elements in the system, without which we can't do anything. There's some interesting work, for instance, on how technologies influence the work we can do. Lara Varpio's work from a few years ago on electronic medical records and how that influenced people's ability to collaborate on a team. Some really interesting work on structure, things as basic as the way shifts are scheduled, or the way people rotate on and off teaching teams in internal medicine, for instance. Those are structures that influence collaboration just as much as the interaction between two people does. And policy, Stella Ng has some really interesting work looking at how privacy legislation actually influences providers' ability to work collaboratively together. I think we need more attention to this, or we're at risk of just looking at whether people have skills, even groups of people, and not how those skills can actually be enacted given the resources available in a particular situation. And then finally, I think we need to start looking at the cracks between the care episodes. Psychometricians hate this. Basically what I'm saying is we need to look at what's not there. How do you measure what's not there? But when I have talked, I've never asked anyone that I've observed or interviewed, what do you think collective competence is? But I've had many conversations with expert clinicians who've said things like this to me. You need to know how the system usually fails in this situation and plan accordingly. You need to know how it will let you down. You use your relationships and history and backup plans to make sure the patient gets safely from A to Z. You can see that these people are not thinking about this care episode. They're probably acting competently in this care episode, and they're not even thinking about the next person that the patient will see. They're thinking about the whole thing and how it's likely to let them down. So how can we see this? How can we get this into the language and into the tools we need so that we can make it visible for trainees in feedback and assessment? How can we make sure people leave training with the ability to know how the system will let them down? Because that's a really critical form of collective competence. So in summary, I want you to take away the idea that competence is a way of seeing, and that as a way of seeing, it directs us to some things and it deflects us from others. At the moment, our attention is predominantly directed towards individual competence, which is necessary and critically important, but insufficient on its own. And we are largely deflected in the way we talk about competence and in the tools we're currently using to assess it from collective competence. We need to have both. I think we have some very good language in place, but our metaphors are holding us back, and so are our conventional approaches to assessment, our expectations of what can be done in assessment and what, of course, can't be done. We need both individual and collective competence. It's going to be a huge challenge, and really, in part, this keynote is a call to innovate. We need to do things differently, and we have the people in this community to figure out how to make it work. It's not impossible. Collective competence can equal good healthcare, and that's why it's absolutely necessary that we face this challenge. Thank you for your attention.
That was outstanding. That was amazing. So we have time for questions. In my enthusiasm to start this session, I forgot to mention that this plenary and all of our plenaries are being webcast around the world. So there's a number of people who I saw were following on Twitter and commenting in their pajamas and various other places. So your comments are welcome, and so are your questions. We'll be watching the Twitter wall now, as well as those in the audience. If you have a question, please come on up to the microphones so that everybody can hear your comments, and I invite you now. And while you're walking, Lorelei, I have a couple comments. So I'm really glad I held my breath when you started talking about CanMeds 2015, because we worked on it for 3 years. And I thought, okay, we're going to have to go back to the drawing board. But no, it's okay, we're on the right direction. But I'm still worried because my department has 3 programs. The country has 800 and some. Eric Hombo's at the ACGME, they have 10,000, Eric, something like that. What do we got to do differently to make this work? It's 21st century, how do we pull it off?
One of the things we have to do differently is not take the language that we produce, which I think has enormous potential, and apply it only to individuals, and particularly to individuals outside of context. So moving into the context, but that's not enough, looking at more than the individual in the context, because we're all perfectly capable of taking everything else out and only seeing Emma, regardless of everything that's going on around her, because we have a form to fill out. We've done some work in past years on the nature of the ITER form and its constraints. I think we're going to need to think very differently about how we translate that language from the framework into assessment tools, because the assessment tools shape our attitudes and our actions too.
Sure. So it's the tools, and I imagine the processes and our rhetoric as well around assessment.
It's everything.
It's everything. It's the whole system. That's Eric Hombo's lecture, by the way, tomorrow. It's a whole workshop. We just did it now in 2 seconds.
Eric has the answer.
Eric has the answer. So we have time for a couple of questions. Brave, intelligent people. This is your chance to ask Lorelei Lingard about what she just said. You're all processing. How am I going to do this? Tanya Horsley, go ahead.
So Tanya Horsley, Royal College Research Unit. So I thought this was a brilliant presentation. Always gets me thinking in a different way. But I'll take it one step further in thinking about, do we have to completely innovate the entire system? So we found it difficult to fail one individual. When we look at collective competence, are we ready to fail teams? And if you have some thoughts about what is that approach and where do we have to go in medical education?
It's really interesting. There's a very provocative report was published about a month ago from the Canadian Academy of Health Sciences. And it's called Optimizing Scopes of Practice. It's by Jeff Turnbull and Siobhan Nelson and a group of folks who worked with them. And one of the things that it suggests is that in order to make sure patients get the care they need in the settings in which they're in, we need to think about licensing differently. We need to think about licensing groups. We need to think about accrediting groups. We need to think about paying groups. I mean, they sort of throw it all up in the air and say, none of these are sacred cows. We actually need to think through, because if we stick with any of those and say, that's a sacred cow, we don't change how funding flows, we don't change how licensing happens, then I think we'll continue to be stuck. So I recommend the report. They don't say we should do all these things, but they sort of put everything on the table and say, it really deserves scrutiny, all of it.
Okay. Dr. McRose.
Hello, Lorelei. Thank you very much. I think absolutely you're on the right track, and I think it's a very, very thought-provoking speech. And I guess my question is, I think we can do this. I agree with you there, but who should do this? Because we do work on teams with nurses and other health professionals, and I think it's going to be beyond the Royal College's mandate and probably a lot of groups' mandates to do this. I think we're starting to try to do this, but we're struggling with how to. And do we need a new group that will oversee this aspect of healthcare improvement?
A Royal College of Healthcare Teams of Canada. Thank you for the question. Do we need a new group? I don't know, but what we do need is not to fall back on that it's outside our mandate. Because in effect, it's everyone's mandate, and when it's no one's mandate, that's when you have a maze of disconnected excellent care episodes that patients fall off in between. So I think everyone needs to be concerned about it. It is a huge problem. I mean, if you've worked in IPE, you know that even getting 3 hours in a curriculum to bring people together to train them is an almost insurmountable challenge. So I'm not suggesting it's simple. And I think your point about whose mandate is it, how do we actually have that conversation, is a necessary conversation to have. But it doesn't preclude us starting in our area. And it doesn't preclude us being very reflective about the language we choose that positions us in relation to others. I gather that yesterday there was a very hot discussion about the leader language. And I think in part it's related to that. It's not that we shouldn't have leader competencies, it's the positioning that happens in that language. So I think we should do it, we should start, but it's not only our work, obviously.
Lorelei, I'm keeping one eye on the Twitter wall. So what do you think of this movement towards in situ simulation with all the members of the healthcare team working on a simulated case? So some of the simulation leaders in the room in Canada are starting to do this in real time. Is that an aid or a hindrance?
I think it's an aid because it's in situ, but I think all of the same suggestions would still apply. So are we still focused on individuals, or are we looking at interactions among the group? Are we evaluating individuals, or do we have some mechanism for talking about how the group is measured, how their performance is measured? I think it's a necessary step in the right direction, but we can still do all the same things and just be simulating in situ and not be a whole lot further ahead.
Okay, we'll go over here. Dr. Batty, did you have a comment? No, you're good? Okay, we'll go over here, sir.
Mark Wilson, the University of Iowa. Thank you for helping us all think about this incredibly challenging area. One piece I'm wrestling with is simply adding in situ assessments may still be very inadequate, because physicians are in all different sorts of teams, and at any given time they may be able to perform well in a certain team. So one of the issues you raised was adaptive capacity. Could you comment a bit more about how we should think, teach, and foster growth of adaptive capacity, which then will feed into how we should assess it in the future?
Absolutely, and that word adaptive is a really key word. So it helps us move beyond just moving to in situ and assessing and saying you're good. So we're in situ, but we're still working on the premises of the individualist model, that it's stable and it's context-free, and if you're good now, you're good forever. If we know that the floor is always shifting under people, and that their ability to be competent is going to change according to whether there's the equipment that they're used to, or whether the other people on the team today have been trained in the same ACLS protocol that they were trained in or in a different one, all of those things, then one of the key competencies would be, can you quickly assess how this situation is new, and can you adapt to it? Can you anticipate where it might go wrong? Can you make reasonable comparisons between what you expect, what you usually assume, and what's going on here? And I think when we go to develop milestones in our individual locations, that's going to have to be key, because I think one of people's worries about milestones is a rubber stamp, but what if they encounter this situation in a completely different set of circumstances? So it's going to be really key in milestones, and I think there are some key phrases that need to be in there. And then the assessments have to have the flavor of fluidity. And assessment and fluidity is an oxymoron. So we really have to work at that.
Okay, so new technology. We have time for just 2 questions. Go ahead.
Karine Nartzi from Ottawa. I was just wondering about, when you talk about collective competence, what about the role of patients and their actual competency of actually maybe bridging those gaps? Because patients now should be advocates for their own healthcare. So what about including them as part of the team?
So I think in my notion of the collective, the patient is there. And that's one of the reasons I tell Joe's story, and I didn't make that explicit. So thank you for the question. In Joe's situation, I would argue that part of the collective competence that's missing is an accurate assessment of Joe's ability to be the carrier of his information through the system. We do increasingly expect patients to tell us what's new in case we didn't find out from some other venue. And I think one would want to assess a patient like Joe and say, is Joe up to date? If Joe doesn't tell me anything's changed, then is that a good marker that nothing's changed? And I think some assumptions are possibly made about Joe and his role on the team. I also would want us to be wary of assuming that the patient is the panacea for the maze of disconnected care episodes. They have a role to play, but they're not the solution.
Okay, so last question, but don't go after this question, because we have a couple of announcements, and I'll tell you how you can win free stuff. So last question, it's going to be a great one. Go ahead.
Actually, I want to hear how you can win free stuff now. Great presentation. Thank you so much. And I humbly stand here in front of you, and I feel like I'm going to ask a question, and I may be blinded and deflecting. Because I feel like part of it is, are the gaps a gap in communication? And again, maybe I'm just boiling it down to something so simple as communication, as being the silos that we're seeing in the individual competencies, and how do we bring that all together in a collective competency? Because even talking back to the patient, Joe, does he have, can we assess his understanding? Well, that's in part, I would argue, communication to the patient. How much does the patient understand of what is going on? And how do we communicate between health professionals, and not necessarily in words, spoken words, but as well through electronics, technology, using the system that we have with the limitations of the system. At the end of the day, how do we pass on that information? Any comments about that?
Absolutely. So I study communication for a living. I also want this to be all about communication. I have a vested interest in this being all about communication. And I think communication is a huge part. We know it's a huge part of patient safety, quality of care, malpractice. It's everywhere. It's a major player. I think it's the way we talk about communication. It's not about communication skills, nor is it necessarily about communication episodes. The communication, each of those communication episodes that Joe had, they could have been different, and still the communication threads throughout the system could have been broken at certain places. And that might not be something that any individual in the system through their own competence could solve. So I think communication is really critically important, but the way we think about communication skills, I think focuses us down in on the individual, and I think we need to think about communication threads or communication systems to help us think about those other dimensions of communication.
Amazing. Can I call on our president of the Royal College, Dr. Cecil Rohrbeck, to come up for a brief presentation?
Reporting for duty. That was a great lecture, I got to say, Dr. Lingard. And I want to thank you very, very much on behalf of the Royal College of Healthcare team, or Royal College of Physicians and Surgeons, for such. Somebody used the word brilliant, and I thought it was an absolutely brilliant and stunning lecture. I mean, we focus so much on individual competencies, but to consider that as a collective is something which, certainly for me, was very novel. So I want to thank you so much for being here this afternoon and doing this. And as luck would have it, we do have a freebie. So we have I guess, a testament to your lecture this afternoon. So I want to thank you again, most sincerely. Thank you. Thank you.
Can I get the two of you to step in front here for a photo?
Yeah.
Sure. So Lorelei is our 2014 Royal College Lecturer in Residency Education. Thank you, Lorelei. That was amazing. Thank you.